the Division of Operations. The Office of Long-Term Living's very own Critical Incident Management team, which is part of our Division of Participant Supports, has put together today's incident reporting presentation for you. You may recognize some of their faces from their presence at our new provider training that you all should have completed within the first 180 days of your enrollment as an OLTL provider. Critical incident management and the reporting of critical incidents are topics that are governed by regulations that you, as an enrolled provider, are required to adhere to. One of the requirements for you to become an enrolled provider and to maintain your enrollment is to provide a staff training policy where your reporting critical incidents is one of the 6 training topics that your agency must implement as an annual training for your staff members. This is part of the 55 PA Code Chapter 52.21. OLTL has partnered with Deering Consulting to create trainings for our providers to highlight many different topics to ensure that your agency remains compliant with the regulations. You're probably already familiar with the Deering website, as that is where you had to complete the 2 online modules for provider training in order to be able to attend that new provider training. So on that same website, there is a training specific to incident management and protective services. It is highly recommended that you and your staff take that training. Your agency could even use that established training to fulfill the requirement for the annual training on reporting critical incidents, which is required in Chapter 52.21. So thank you very much for being here to further your knowledge on critical incidents. Without further ado, I will turn the presentation over to Brian Lester. Thank you.
Hello, I'm Brian Lester. I'm with OLTL's Bureau of Fee-for-Service Programs in the Division of Fee-for-Service Operations, and I'm the supervisor for the Participant Services Review Team. I wanted to mention a few quick items for this webinar training. I was going to point out how this training applies to the OBRA waiver due to some waiver reporting considerations for that specific waiver. However, what I have to note would also apply to all OLTL waivers in Act 150. So please make sure to pay close attention to what's covered regarding the specific actions that need to be taken within 24 hours of an incident, as well as what specific actions need to be taken within 48 hours of an incident. Please also consider that the mandatory incident reporting requirements are just as important as the other areas of work that you do to support OLTL waiver program participants as service coordinators, as well as direct service providers. Ensuring these incident reporting requirements are consistently met may potentially impact the overall operation of OLTL's waiver programs at the program level, as well as potentially impact participant services and risk mitigation strategies at the individual participant level. So thank you, and I will now turn the rest of the webinar training over to the lead OLTL webinar host, Damaris Alvarado. Thank you.
Good morning. Thank you, Brian, and thank you, Tara. Good morning, everyone. My name is Damaris Alvarado. I am the Section Chief of the Critical Incident Management Unit in the Office of Long-Term Living. And with me today, also from the Critical Incident Management team, is Beth Manbeck. She is a registered nurse who works with both fee-for-service as well as Community Health Choices participants. A few housekeeping items before we begin. First is that this session is being recorded. Joining and remaining at this session constitutes consent to the recording. Your microphones will be muted. Please use the chat box to communicate with us. We will be monitoring your attendance, and you will receive confirmation for attending today only if you're present during the entire 2 hours and if you're showing active participation. Today's session will focus on reporting of critical incidents. We will not be covering investigations and closing of critical incidents. Our presentation is composed of 2 parts. The first one focuses on incident management policy and procedure. The second part focuses on the actual documentation of the incident report's first section in the incident management Enterprise Incident Management System, or EIM. We have a lot of information to cover, so in order to make the best use of time, we ask that while we're presenting, if any questions come up, you can please write them down. If we do not answer your question throughout the presentation, please enter your question in the chat box. We will do our best to answer your questions today. If we're unable to because of time, we will make sure that we send you a response via email. The PowerPoint and today's recording will be available on the Department of Human Services website within the next few weeks. Again, the session is being recorded, and by you joining and staying with us today, you are consenting to the recording. If you give me a few seconds, I will start sharing my screen and begin our presentation. Thank you. Our objectives for today are to review critical incident management requirements and emphasize to Office of Long-Term Living home and community-based services providers what is a critical incident, who is responsible to report a critical incident, and when to report a critical incident. Our goal is to help bridge any potential gaps of communication and underline the importance of having a teamwork approach when addressing critical incidents. Why is this important? When Pennsylvania applied to the federal government in order to provide waiver services, we agreed to specific health and welfare assurances and were accountable to our participants, as well as to the Centers for Medicaid and Medicare Services. We recently provided reports to CMS for both OBRA waiver and Community Health Choices participants, which reflected a decrease in compliance as well as non-compliance with critical incident reporting timeliness in some areas of the state. We are reviewing these requirements again today with the goal to improve performance in the very near future. The critical incident management requirements are outlined in various policy and procedural documents we have developed internally. The actual law is found in Title 55 of the Pennsylvania Code, Chapter 52. I would like to call your attention to the fact that our Critical Incident Management Bulletin has been updated with an issue date of February 23rd, 2023. And we would like to encourage you to find this new Critical Incident Management Bulletin on the DHS website. It was also distributed via listserv a few days ago. Please take a moment to review it and see the changes. Most of the changes were for better wording and presentation, as well as to remove items that are no longer applicable. For example, the old 2015 bulletin spoke about paper incident reports for aging waiver participants. As we know, there are no other methods of reporting critical incidents except for the Enterprise Incident Management System. Also, the aging waiver participants are now part of the Community Health Choices waiver. The requirements already mentioned call for all providers, service coordinators, and managed care organizations who are enrolled to provide services under the Office of Long-Term Living Programs to report critical incidents in the Enterprise Incident Management Electronic System, or EIM. There is a special requirements for providers of direct care services or caregivers. You're also required to report all critical incidents to the assigned service coordinator. This is a separate notification completed via email or whichever method of communication you have agreed upon with the service coordinator. It is only through partnership that we're able to ensure the participants' health, safety, and welfare. We cannot successfully address the participants' needs if we do not maintain open lines of communication, collaboration, and documentation between the service coordinators and service providers. Since each MCO might have specific procedures, we ask that if you have a specific questions about a critical incident for a Community Health Choices participant, please contact the individual MCO. We wanted to repeat the additional training requirement that is found in 55 PA Code Chapter 52.21, which Tara mentioned earlier. It requires a provider to implement standard annual training for all staff members who are providing services, and the training must contain at least the 6 elements shown on the screen. I'd like to call your attention to number 2, reporting critical incidents. In addition to reporting critical incidents, all CHC MCO service coordination entities and direct service provider staff are all mandated reporters under both the Adult Protective Services, or APS, for individuals 18 to 69, and the Older Adult Protective Services, OAPS, for individuals ages 60 and older. Therefore, if there is any suspected abuse, neglect, exploitation, or abandonment, the person who discovers the incident must also contact the appropriate protective services agency based on the age of the participant. When an agency becomes enrolled to provide services under any of the Office of Long-Term Living programs, our enrollment staff sends a welcoming email with a letter and a few attachments outlining the various requirements for providers and service coordination entities. The training for providers and service coordinators includes an online training, which is a prerequisite to a 1-day classroom training or a 2 half-day virtual training currently offered by our contractor Deering Consulting. The image on this slide should be very familiar to you, as it is part of the online training, which explains that providers are required to train employees upon hire and annually on prevention, identification, remediation, and reporting by developing policies, procedures, and practices. The training goes on to explaining that critical incident management is part of the required training, and it includes prevention and trend tracking, risk management, investigations, reporting, and notifications. We will provide you with this slide, with the link to the training on a future slide. Let's talk about individuals' rights. As we know, participants have the right to make choices as long as they are within the laws and regulations of the Commonwealth of Pennsylvania. These choices can be regarding their lifestyles, relationships, their bodies, their health, even though some of those choices may present a risk to themselves or their property. Participants also have the right to refuse to cooperate with reporting critical incidents. However, all MCO service coordinators and direct service providers must report critical incidents even when the participant does not wish you to do so. We encourage caregivers and service coordinators to communicate early on in their relationship with the participants to inform them of your responsibilities to report critical incidents. Make sure your participants understand that these requirements are mandatory and that you must report certain events even if the participant does not want you to do so. There are two basic elements to critical incident management. Number one is that before a critical incident is reported, the person or entity who first discovers the incident or learns about the incident must take measures to ensure the health, safety, and welfare of the participant. This may include calling 911, perhaps contacting a protective services agency, law enforcement, or the fire department if the event merits calling those authorities. Number two is that after the participant is safe, the entity who discovered or first learned of the incident must determine whether it is a reportable incident. How do we determine what needs to be reported? Let's go over the critical incident criteria. The definition of a critical incident is an occurrence of an event that jeopardizes the participant's health or welfare, and it includes the following: abuse, which is the infliction of injury, unreasonable confinement, intimidation, punishment, or sexual abuse of a participant. There are several types of abuse. Please note the following list is not all-inclusive. Physical abuse is defined as a physical act by an individual that may cause physical injury to a participant. An example, a caregiver reports to their shift, finds the participant crying. The participant reports that her grandson, who has a mental disability, had a breakdown, punched her, and therefore she had bruises and had some bleeding in her face. This is an example of physical abuse that should be reported as a critical incident. Psychological abuse is defined as an act other than verbal that may inflict emotional harm, invoke fear, or humiliate, intimidate, degrade, or demean a participant. Example, participant called the service coordinator to report that his daughter has turned off the TV, any communication with other family members, their internet service, and also told the participant that if he reported her actions, she will make sure that he goes to a nursing facility. An example of psychological abuse that must be reported as a critical incident. Sexual abuse is self-explanatory. Any sexual act, as well as any inappropriate or unwanted touching of a participant, must be reported as a critical incident. Please note that even if a participant reports an event that happened in the past, it needs to be reported as a critical incident. And please be alert to any signs of sexual abuse and be diligent in reporting it. Next is verbal abuse, defined as using words to threaten, intimidate, harass, or humiliate a participant. An example would be a participant reports to the caregiver that her son yells and uses profanity when the participant asks that the son does something for her. This is also an example of a reportable critical incident. Next is neglect. It includes the failure to provide a participant the reasonable care they need. It includes, but is not limited to food, clothing, shelter, personal hygiene, medical care, and protection from harm. Also, a form of neglect is secluding an individual by involuntarily confining them alone in a room or area and preventing that participant from having contact with others or from leaving the room. An example of neglect would be a person who is living in deplorable condition. The participant has not received care from the caregivers for a few days. The service coordinator makes an unannounced visit and finds that the participant is sitting in his feces. There's a very strong smell of urine. There is dirt all over the house, and the participant does not look like he has bathed in a few days. This is an example of a neglect case that must be reported as a critical incident. Exploitation is the act of depriving or defrauding, as well as obtaining personal property from a participant without their consent or knowledge for the benefit of self or any other person that is not the participant. So an example of exploitation would be a person who takes a participant's cash money to buy groceries and then tells the participant that they use the EBT card, but really they took the participant's money for themselves. That would be an example of exploitation that must be reported as a critical incident. Next is death other than by natural causes. So this will include any homicide, suicide, any death that occurs as a result of neglect or abuse are all reportable as critical incidents. One important note is that we have a new secondary category of unexplained for a death category of a critical incident. We are requesting that you do not use the secondary category in the incident first section. Upon discovering a critical incident or a death, if you're not sure what the cause of death was, we're asking that you use suspicious as a secondary category. The secondary category of unexplained is for use only in the final section once the coroner has determined that the cause of death cannot be verified. So again, if you are a direct service provider and you're reporting a death that occurred because of other than by natural causes, you will not be using secondary category of unexplained in the first section. If you do not know the circumstances surrounding the death, you will use suspicious as a secondary category. Next is serious injury, which is an injury that causes a person severe pain or significantly impairs their physical or mental functioning, either temporarily or permanently. An example would be a participant who's walking outside and trips and falls and breaks a leg or an ankle. And as a result, they need to go to the emergency room to receive treatment or medical care. Next is hospitalization. Please note you will only report a hospitalization if it is unplanned. If the hospitalization was a routine or scheduled procedure in a hospital or clinic, is not reportable as a critical incident. So this will be any unexpected hospitalizations. If the person gets sick and is taken to the hospital, if the person has an accident, a fall, anything that was unexpected and resulted in admission to a hospital is reportable as a hospitalization. If the person was pre-scheduled to have any type of procedure or surgery, those are not reported as critical incidents. If a person is scheduled to have some sort of surgery, and while having the procedure done, there are complications that result in hospitalization longer than expected, then it is reportable as a critical incident because the complications were unexpected or unplanned. Next is provider or staff misconduct. It includes deliberate, willful, unlawful, or dishonest activities. An example would be a caregiver who accompanies a participant to do grocery shopping, and while at the grocery store, the participant reports that the caregiver took some items from the store and did not pay for them. That is an event that must be reported as a critical incident. Next is restraint. It includes any physical, chemical, or mechanical intervention used to control acute episodic behavior, which restricts the movement of the individual or a portion of the individual's body. Also, use of restraints is secluding an individual by the use of restrictive interventions. So restraint would be, an example would be a participant who needs a walker to mobilize, but her daughter and son-in-law refuse to give it to her because the neighbors complain of the noise it makes while she uses the walker. In this instance, the participant is being restricted because she cannot mobilize otherwise without the walker. Restraints are not devices used for the safety of participants. For example, if you are transporting a participant in their wheelchair to the grocery store and you are using the seatbelt to secure the participant to the wheelchair, that is not the use of restraints. It does not need to be reported as a critical incident. If the participant gets in an altercation, the police are called and the participant gets arrested and handcuffed, that does not meet the criteria of a critical incident report, and it does not need to be reported. Next is service interruption, which includes any event that results in the participant's inability to receive services, and because of that inability to receive services, the participant's health and/or safety are placed at risk. It includes involuntary termination by the provider agency and failure of the participant's backup plan. If these events occur, the provider agency must have a plan for temporary stabilization. So a service interruption has to be reported as a critical incident if the participant's health and safety were at risk. For example, the participant did not receive services for a few days in a row. As a result, they were unable to eat well or take their medications. An example of a service interruption that does not need to be reported as a critical incident would be a participant whose caregiver didn't show for a few shifts. However, the neighbor, a family member, or any other support person care for the participant in the meantime. So if the participant was safe during that service interruption, it does not need to be reported as a critical incident. Next is medication errors that result in a hospitalization, an emergency room visit, or other medical intervention. An example would be a participant who was distracted and as a result took too much medication or insulin and their blood sugar dropped below normal levels. The participant needed medical attention in an emergency room. That is an incident that must be reported as a critical incident. If there is a medication error that does not result in a medical intervention, for example, a participant took medication at a different time, forgot that they took the medication and took it again, but there were no adverse effects, that does not need to be reported as a critical incident. A few examples of events that are not critical incidents and do not need to be reported in EIM. Complaints. These are different from critical incidents and should not be reported in EIM. However, the service coordinator should address them if it becomes a concern or an issue for the participant. For example, dissatisfaction with services is a concern that needs to be addressed, but it does not need to be reported as a critical incident. Program fraud and financial abuse should be reported according to our bulletin. Normally is reported to the Bureau of Program Integrity, but it does not need to be reported as a critical incident unless the participant's health and welfare were at risk. Let me give you an example of a fraud and abuse case that does not need to be reported as a critical incident. A caregiver is providing services to two participants at the same time. That constitutes financial or fraud, financial abuse. However, because the participants are both safe and receiving the services they need, it's not reportable as a critical incident. A missed shift that does not place the participant's health, safety, or welfare at risk is not reportable as a critical incident. Again, if the participant received the care they needed, even though the caregiver called off and there was no replacement, it does not need to be reported as a critical incident. A death that is due to natural causes is not reportable as a critical incident. If a person passes away of a long-term illness or an unexpected cardiac arrest, complications from an illness that they had, those are all considered natural deaths and do not need to be reported as critical incidents. I'd like to call to your attention the fact that while the COVID-19 emergency was in effect, the Office of Long-Term Living was asking for providers and service coordinators to report COVID-19 related deaths. This is no longer a requirement. As you might know, COVID-19 deaths are considered a death due to natural cause, and it's not reportable as a critical incident. A pre-scheduled medical procedure in a hospital is not reportable as a critical incident. As I mentioned earlier, if there are complications from the procedure and the participant is hospitalized as a result of the complications, then it is reportable as a critical incident. Let's talk about critical incident reporting timeframes. The entity who first discovers or has firsthand knowledge of a critical incident is responsible to report it. Whoever learns about the event first is responsible to report it. A direct service provider who discovers or has firsthand knowledge of the critical incident must also inform the service coordinator within 24 hours of discovery. So it's direct service provider has 24 hours from the time they learn about an incident to contact the service coordinator and inform them of the incident. The service coordinator or direct service provider who discovers or learns about the incident must also submit the first section of the critical incident report to the Office of Long-Term Living within 48 hours of discovery using the EIM system. Again, 48 hours from discovery of the incident is the requirement to submit a critical incident report in EIM. There are no other methods of reporting a critical incident to our office. We do not accept paper forms for critical incidents. All critical incidents must be reported in the Enterprise Incident Management System. If you are a direct service provider and you're unable to determine if the service coordinator already submitted an incident report in EIM, play it safe and submit an incident report. If there are duplicate incident reports, the Office of Long-Term Living staff will review upon final submission, determine if they are two of the same, and delete the one that does not need to stay in EIM. So again, because you don't have access to all of the participants' incident reports in EIM, if you're unable to determine if the event was already reported, play it safe and submit another critical incident report. If the incident was discovered on a weekend or a state holiday, the 48 hours begin at 12 a.m. on the first business day after discovery of the incident. We will also provide you with a link to the state holiday calendar that you can use to determine which days are excluded when you are trying to count the hours to submit a critical incident in EIM. Let's look at the reporting timeframes on a flowchart. Within 24 hours of discovery, the direct service provider will notify the service coordinator, and within 24 hours of learning of the incident, the service coordinator will begin the investigation. Within 48 hours of discovery, whichever entity first discovered or became aware of the incident, so this could be the direct service provider or the service coordinator, they must ensure the first section of the incident report is submitted in EIM. If there is protective services involvement, the service coordinator must ensure they make contact with the protective services staff and collaborate or cooperate with their investigation. And within 30 days of discovery and upon completing the investigation, the service coordinator will complete and submit the incident report's final section in EIM. So we have 3 different timeframes here. We have 24 hours from discovery, where a direct service provider will notify the service coordinator. Within 24 hours, the service coordinator will begin the investigation. Within 48 hours of discovery, the first section of the incident report must be submitted in EIM. And within 30 days of discovery, the service coordinator will complete the investigation and submit the final section of the critical incident report in EIM. What happens if the incident or the event occurs at a time that you are not working? Are you still responsible to report the critical incident? Yes. The Critical Incident Management Bulletin, now issued February 23, 2023, but was also indicated in the old 2015 Critical Incident Management Bulletin. It indicates that it is mandatory for MCOs, service coordinators, and provider agencies who discover an incident to report it, and that this applies to incidents that happen at any time. It includes incidents that occur during the time a service is being provided, as well as incidents that occur during the time an agency is contracted to provide services but was not providing the services, and incidents that occur at times other than when an agency is providing or contracted to provide a service, if your agency becomes aware of such incidents. Let's go over some examples. First scenario, on Friday, March 3rd at 2 p.m., the direct service provider arrives for their shift and finds John on the floor complaining of leg or hip pain. He's unable to get up and tells the service provider that he fell while trying to heat up a frozen meal for lunch. March 3, 2023 at 2 p.m. is your incident discovery date and time. Step number 1 will be to immediately call 911 and ensure the participant receives medical attention. Step 2, by 2 p.m. on Saturday, March 4th, which is 24 hours from incident discovery, the direct service provider will notify the service coordinator of the event. I will add that whether you have the responsibility to report these critical incidents, it's completely independent from whatever arrangements you have with your agency. And let me explain that a bit further. You must ensure that you have an arrangement and that you're clear about what the expectations are when you are off the clock, because reporting critical incidents is a mandatory requirement. So on a Saturday at 2 p.m., you may not be on schedule to work, but if you became aware of an incident on Friday at 2 p.m., you have until Saturday by 2 p.m. to let that service coordinator know. So please make sure that your agency protocols are well known and that you know exactly what you need to do when something happens outside of your work hours. The critical incident report must be submitted in EIM 48 hours from the time of discovery. In this instance, it will be by 1:59 p.m. on Tuesday, March 7th. If you count from 2 p.m. on Friday, March 3rd, and you exclude Saturday and Sunday, from 2 p.m. to 11:59 p.m. on Friday, that is 10 hours that count towards your 48 hours. There are 24 hours on Monday, and then from 12 a.m. to 1:59 p.m. on Tuesday, will be your total 48 hours. So by 1:59 p.m. on Tuesday, you must ensure the incident first section is submitted in EIM. I'll give you a few seconds to review the example. We've also provided a visual for you to see the clocks, again, from 2 p.m. on Friday, March 3rd through 1:59 p.m. on Tuesday, March 7th. This is how you count your 48 hours. And you must ensure that critical incident report is submitted by 1:59 p.m. because if 2 p.m. comes on that Tuesday, then it will be past your 48-hour time frame. Let's look at a second example. On Saturday, March 4th at 10:30 p.m., John texts the direct service provider saying that he fell while he was transferring into bed around 8 p.m. He had already called his family, who called 911. EMS responded and transported John to General Hospital. March 4th, 2023, at 10:30 p.m. is your incident discovery date and time. You will immediately contact your agency. If you are a direct service provider, again, you must know your agency's protocols for when an incident happens. We are thinking that there is a process in place where if an incident happens, you will contact your provider agency, but make sure that you follow whichever protocols you have in place in your agency. The second step would be to notify the service coordinator within 24 hours. So you will count 24 hours from 10:30 p.m. on March 4th when you were notified of the incident. And then 48 hours from 12 a.m. on Monday, March 6th. Remember, you will be excluding Saturday and Sunday. So by 11:59 p.m. on Wednesday, March 8th, you must ensure the incident first section is submitted in EIM. Please note the difference between this scenario and the previous scenario. In this instance, the direct service provider became aware of the incident on a Saturday at 10:30 p.m. Saturdays and Sundays are excluded from the 48-hour count. Your clock will start on Monday at 12 a.m. Therefore, 48 hours from Monday at 12 a.m. will expire on Wednesday, March 8th by 11:59 p.m. Then you will collaborate with the service coordinator in the investigation. And again, we'll like to provide some visuals for you to become familiar with how you need to count the 48 hours. And I will again give you a few seconds to review the example. Third scenario. On Friday, March 3rd at 10:30 p.m., the service coordinator is contacted by John's family to alert her of the fall or injury and the admission to General Hospital. March 3rd at 10:30 p.m. will be your incident discovery date and time. By 10:30 p.m. on Saturday, which is 24 hours from 10:30 p.m. that Friday, the 3rd, the service coordinator will begin the investigation. The service coordinator will also alert the direct service provider agency so that they can hold services since John is in the hospital. By 10:29 p.m. on Tuesday, March 7th, the service coordinator will ensure the incident report first section is submitted in EIM. Again, we would like to explain how you count the 48 hours. From 10:30 p.m. on Friday, March 3rd, you will exclude Saturday and Sunday. From 10:30 p.m. on Friday to 11:59 p.m. on Friday, remember you have 1.5 hours that you must count towards the 48 hours. You add 24 hours on Monday plus 22.5 hours that you're counting from 12 a.m. to 10 p.m. on Tuesday. That is why on that Tuesday, March 7th, by 10:29 p.m., you must ensure that first section of the incident report is submitted in EIM. An additional requirement for service coordinators is to investigate critical incidents and make sure that the critical incident report in EIM is submitted to the Office of Long-Term Living for review. This must be done within 30 days, 30 calendar days from discovery. Please note that in the 30-day count, weekends and holidays are not excluded. Here's your visual, again, for the timing. You will submit the first section by 10:29 p.m. on Tuesday, March 7th, 48 hours from discovery date and time. And we added a calendar to remind you, you have 30 calendar days to investigate and close the incident report in EIM. As you can see, reporting critical incidents is the responsibility of both direct service providers and service coordinators, depending on which entity first became aware of the critical incident. Would like to emphasize that reporting that critical incident should never be a debate. So if you don't know whether the critical incident has been reported, please make sure you submit the first section of the critical incident report in EIM. And I like to emphasize, if there are duplicate incidents, we will take care of deleting the unnecessary critical incident report from EIM. Let's move on to notifications to the participant. The participant has the right to know that a critical incident report has been filed for an event that they were involved in. Therefore, our policy requires that within 24 hours of the report, the agency staff who first became aware of the critical incident notifies the participant and their representative, unless the representative is involved with the critical incident. So again, 24 hours from filing that report, whoever submitted that critical incident in EIM must let the participant and their representative know that they have reported a critical incident to the Office of Long-Term Living. Again, if the representative is involved in the critical incident, they should not be notified. When the direct service provider is the incident initiator, they must confirm to the service coordinator that you have notified the participant so that the required field in EIM's incident final section can be completed. And there's an example of the field that appears in the final section. It is a mandatory field that asks whether the participant was notified within 24 hours that a critical incident report has been filed. The service coordinator is responsible for completing this field, but if the direct service provider was the one who submitted the first section in EIM, she's not going to know unless she's informed that the participant was notified. So again, open lines of communication, collaboration, and documentation. Another part of critical incident reporting is that service coordinators, as well as MCO staff, are responsible for ensuring the health, safety, and welfare of participants by implementing risk mitigation measures and preventing abuse, neglect, exploitation, or abandonment. We all know that even though we put forth our best efforts, there are still certain events that will occur. Although all incidents that are reported to Adult Protective Services and Older Adult Protective Services will require a critical incident report in EIM, there are certain critical incidents that do not rise to the level of a protective services referral. You will always refer any incidents that involve abuse, neglect, exploitation, or abandonment to the Protective Services Agency. Other reports that do not rise to that level would be, for example, a hospitalization that was a result of an illness and not a result of abuse or neglect, or an emergency room visit also for illness. Those are not incidents that need to be reported to the Protective Services Agency. We'd like to remind that providers play an essential role in this process. The Department of Human Services expects service coordinators and MCO staff to implement these measures so that we can prevent these events from happening. When there is an incident that involves suspected abuse, neglect, exploitation, or abandonment, after ensuring the participant's safety, you are required to make a report of need to Protective Services by contacting the hotline. The number is shown on your screen. So first, you make sure the participant is safe by contacting the appropriate agency, which might be police, crisis intervention, the ambulance. But remember, you must also make that call to the 800 line to make a report of need to the Protective Services Agency. Once you make that call to Protective Services, the agency will determine the priority level of the report of need and whether it will be assigned for investigation. Once Protective Services is involved, they are responsible for investigating the allegations. Any allegations of abuse, neglect, exploitation, or abandonment that are referred to Protective Services will be investigated by their staff. The service coordinator and provider agency staff will cooperate with Protective Services in their investigation. However, they will not be investigating the event. Once the investigation is completed, if the allegations are substantiated, the Protective Services Agency may provide or arrange for services to protect the adult and ensure their immediate safety. This plan will be developed in collaboration with the service coordinator and the provider. Reminder about critical incident report documentation. Remember that state entities are viewing your reports, so each critical incident report must account for background information relative to the event and explanations of who is involved and what happened. Keep in mind that a critical incident report may very easily become a legal document, and there are instances of abuse and neglect that are referred to the Office of Attorney General for prosecution. In those instances, it is very possible that you might be called to court so that you can testify to that critical incident. Please ask yourself, if you read the critical incident report in court, would it paint an accurate picture of what happened, the participant's life, and the steps that you took to ensure health and safety? Another reminder is that the EIM incident report is a real-time document. It must be kept up to date with the most recently known information. At the Office of Long-Term Living, our staff reviewing critical incident reports have found that some providers, service coordinators, are waiting until they conclude their investigation to enter all their notes and findings into the incident report's final section. We're asking that you treat the critical incident report as a real-time document, and that every time you take an action or that you make a contact as a step of your investigation, that you immediately document it in the critical incident report. The reason for this is that at the Office of Long-Term Living, we're unable to determine what is going on at that time with the participants' health and safety if we're unable to read the steps that you're taking to ensure that. So please make sure that as you go through your investigation, this is for the service coordinators, you immediately go to that incident report in EIM and you document your actions on real time. And a last reminder about incident report documentation is that everyone uses abbreviations differently. You may abbreviate the word participant in a way that means something else for someone who is reading your critical incident report. This is why the use of abbreviations in a critical incident report is strongly discouraged. Critical incident report information is considered confidential. You should only release information about a critical incident to essential personnel such as police, medical personnel, protective services staff, crisis intervention, and the only purpose for releasing that information should be to ensure the participants' health and welfare and/or to complete the critical incident report. Please remember that these confidentiality requirements are also part of Pennsylvania Code 55, Chapter 52.29. So if you have any questions about the confidentiality requirements or whether you can or cannot release information to a certain personnel or staff person, make sure that you review the requirements that are outlined in the law. This concludes our policy and procedure part of the presentation. I will now hand over the presentation to Beth to talk to us about documentation of the critical incident report in EIM.
Thank you, Damaris. Good morning, everyone. Thanks for joining today. Let's spend some time together looking at actions within EIM which contribute to compliance with the incident first section submission at the required 48-hour submission period. As already noted, service coordinators and direct service providers should be trained in the use of EIM. Hands-on training at the agency level can be coupled with reference guides located in the HCSIS Learning Management System, often referred to as LMS. The Office of Long-Term Living and Managed Care Organizations act as additional resources. During this portion of today's session, we will use screenshots of an incident to demonstrate how fields can be completed with a comprehensive and accurate description of the event, while also maintaining timely 48-hour submission requirements. I'd like to begin with the review of some general details and reminders about EIM. Each incident has 2 time-sensitive sections for data input by the service coordinator or direct service provider, but today we will focus on the incident first section. There are 9 to 10 subsections, depending upon how the incident is primarily categorized. Beginning in August of 2022, changes were made in EIM to better align with regulation. Now, when the first section of an incident is submitted by the direct service provider, the service coordinator receives notification in EIM that the incident final section is ready for them to enter the investigation findings. We can't emphasize enough the need for direct service providers and service coordinators to check the EIM dashboard daily for alerts and reminders of incidents coming due. I'd also like to point out that users are required to put information into specified mandatory fields in an incident. However, to assure a thorough incident report, we recommend that as many fields as possible are completed on each screen of an incident. All screens within the incident first section must be completed, validated, and submitted within 48 hours following incident discovery. As a gentle reminder, if you don't recall how to create a new incident using the participant's master client index, also referred to as the MCI number, social security number, or last and first name, please reference the LMS guides or consult with your supervisor for assistance. When the initiator searches for a participant in EIM, the system communicates with the HCSIS case management system to pull information into the incident. If a participant cannot be located in EIM, we ask that you consult your supervisor. As we begin, please note, the following screenshots were developed in EIM's test environment and are intended for demonstration purposes only. Throughout this portion of the training, I will use the terms initiator and user interchangeably to refer to the person who is entering the incident in EIM. So let's begin. This is a view of the individual information screen. We're looking at the top part. This is the first subsection in the incident first section. When the initiator searches for a participant, information located in the HCSIS database is used to automatically fill these fields with key identifying information, such as MCI number, name, waiver or program name, and date of birth. Always be sure that the participant's name is listed correctly and verify that the waiver or program enrollment is also shown accurately. This is the bottom half view of the individual information screen, which displays the participant's contact information, service coordination entity, and assigned service coordinator. For CHC waiver participants, the MCO name will also display. Because the information on this screen will autofill, it may be very tempting to quickly click Save and Continue. However, we strongly encourage a review for accuracy before moving to the next screen. Errors should be referred to your supervisor so corrections can be made within HCSIS by your agency's business partner administrator. Incident initiator information pre-populates based on the initiator's enrollment as a HCSIS EIM system user who is also authorized to provide services for the participant. Please check this screen and alert your supervisor if inaccuracies are noted. To access the provider information screen shown here, the initiator must complete the provider search screen by selecting their agency's provider name and service location ID number. The provider information fills automatically, except for 3 fields shown at the bottom of the screen. When the initiator enters their agency's provider type from a drop-down menu and the first and last name of the agency staff, the screen is complete. Incident classification is the 4th subsection in the incident first section. Classification is determined based upon the details gathered from sources such as the participant, hospital staff, law enforcement. It could be friends or neighbors, the direct care worker, a protective service investigator, and the list goes on. Discovery date and time play a significant role in 48-hour submission compliance, so it's important to understand how to identify the discovery date. Discovery is when the direct service provider, service coordinator, or anyone from either of those 2 agencies witnesses or is made aware of an event through a text, call, or any other form of communication received from the participant or any other source. Again, discovery is when the direct service provider or service coordinator finds out about the event. Another term used in EIM, which you should be familiar with, is occurrence date. It is the actual date the event happened. A direct service provider or service coordinator may not always find out about or discover the event on the actual day the event occurred. For example, a participant may be admitted to the hospital on Friday of last week, but the direct service provider may not discover until Monday morning when they arrive for their shift and find the participant isn't home. Both the discovery and the occurrence date are needed to complete the incident classification screen. The specific time is also involved in calculation of the 48 hours. Let's take a closer look at discovery date. The user clicks on the small calendar icon, which is found across from the discovery date and time. A calendar opens showing the highlighted default date, which is the current date. In the event the incident initiator is able to gather enough information to initiate the incident report immediately upon discovery, there is an icon saying Now. Clicking Now enters the current date and time. However, If the incident is being entered a while after discovery, date and time can be entered using the features on the calendar. When discovery happens before the current date, the user may change the day by clicking and highlighting a different calendar day. For example, if the direct service provider learned yesterday afternoon that the participant was hospitalized, but they waited until today to enter the incident, the default date would need to be changed. Users can also navigate to previous months and years using the directional arrows located at the top of the calendar. Time plays a role in the 48-hour window to submit the first section. It's important to understand that EIM defaults the time to 12 midnight, which is shown here on the left side of the screen. Frequently, discovery time needs to be changed from the default time. This is easily done using the hour and minute slide bars. In our example, the default was reset to 2 p.m. Had the initiator not reset the time, he would have lost 14 of the available 48 hours to ensure incident first section submission compliance. Incidents are classified using a primary and secondary category. Each primary category has a discrete list of secondary categories which display when you select the primary category. In our scenario today, John fell at home, which resulted in transport to the hospital. Emergency room visit and accidental are the secondary categories. All the events happened on the same day, but sometimes secondary events occur before discovery. There may even be more than one secondary event, and each may have a different occurrence date. It's possible to have 2 or more different dates listed on this screen. This is a bottom half view of the incident classification screen. Let's walk through the information that's recorded here. To begin, take note of the choking falling indicator, which is used when the incident directly involves a fall or choking. We ask that this field not be used to indicate when a participant is merely at risk for a fall or choking. Next, you see the target field, which is used to indicate when a provider is identified as a person involved in the abuse, neglect, or exploitation of the participant. On the following lines, you see the adult and older adult protective service, report of need, referral fields. Incidents categorized as abuse, neglect, or exploitation require a yes response for the indicator, which fits the participant's age. So for example, if your participant is 62 years old, the older adult protective service referral field will be marked yes. For consistency throughout the incident, please use the age-designated term to refer to the involved protective services entity. In the case of our 62-year-old, we would say older adult protective services to describe the protective service entity in all other documentation throughout the rest of the incident. The last field we see here is the COVID-19 indicator, which is used when COVID is suspected or confirmed at the time of the incident. Fields on the reporter screen are completed with information identifying the person who reported the incident. A few options include participant, relative, and provider staff. Reporter type and relationship to the participant are completed using the drop-down options. In our scenario, type is provider, and the relationship is staff person reporting for duty that day. Although the remaining fields are not mandatory, we strongly encourage completion by the initiator. It's very important to note, when the reporter is a provider, a telephone number is required to submit the incident without errors. The incident description should be formatted using a consistent and chronological process to document the event with as many specific details as possible. Names and relationships, locations and times are all critical to understanding what occurred. Save the content, then go back and reread the story that you've written. Would the story make sense to a reader who has no knowledge or understanding of the people involved or the event timeline? There's ample space in this field to provide a detailed explanation of the event. If needed, the document upload feature on the incident details screen can be used to add more details. An accurate, detailed, thorough story reduces the likelihood that the incident will be pended back for additional details during the management review. This is a magnified view of our scenario, where we see that the direct service provider arrives on Friday, March 3rd at 2 p.m. and finds John on the floor. She talks to John, assesses the situation, and finds he can't get up, and he's complaining of leg and hip pain. He told her he fell while going to heat up a frozen meal for lunch and used his personal emergency response system, which you'll sometimes see abbreviated PERS or PERS, right before she arrived. The PERS company told John that the Emergency Management System, or EMS, was alerted, and also told him his family was contacted. We have a fairly solid understanding about what happened to John. Efficiency can be gained when developing the event narrative within EIM by routinely clicking Save to avoid accidentally losing your work. You may also consider drafting on a Word document and then using the copy and paste features to move the information into the designated field in EIM. Now on the initial action screen, we discover what actions the caregiver took to reduce immediate risk. In our scenario, immediate risk has already been addressed through the use of the PERS system. So the caregiver takes the next steps to be sure John can be easily accessed by the EMS team, and she provides support to John while they wait. There was not a target in this event, and services were offered to John, which he declined. The event is told using specific times, moving from the initial contact forward. The writer adheres to a consistent chronological process. The reader captures an understanding of the people and the exact times. Immediate reporting to the direct service provider agency ensures that the caregiver won't forget to make the required report later that day. It also allows the direct service provider agency to begin the required reporting in EIM. On the bottom half of the initial action taken screen, the initiator indicates types of medical attention given. In cases where medical supports are offered but declined, please mark Other and explain in the 4000 count character field. Calls to 911 and law enforcement are also documented on this screen. EIM has conditionally mandatory fields, which means when a certain response is provided for one question, the response to a follow-up question is required. For example, here you see the initiator is asked if law enforcement was contacted. When the response is no, the initiator must explain why police were not involved. A similar question for calling 911 also requires explanation for a no response. When conditionally mandatory fields are left blank, validation errors will result, which may delay incident submission. All incidents should reflect actions taken by the initiator to report the event to agencies such as law enforcement, the managed care organization, and protective services. Other agencies are also listed in the drop-down. Because the direct service provider agency and direct care workers are required to alert the service coordinator within 24 hours of incident discovery, service coordination notification must be listed on this screen. There are a number of asterisks on this screen. Remember, all fields marked with a red asterisk must be completed to submit a section. Failure to complete any field shown with an asterisk will produce errors upon validation, delaying incident submission. When the incident is categorized as abuse, neglect, exploitation, or staff misconduct, the initiator is asked if targets were identified, and a yes response opens a screen with questions which must be answered about the target. To maintain anonymity, EIM only allows for the target's first initial of their last name. More than one target can be listed using the Add and Save buttons. As a gentle reminder, if you're unsure where to find and how to use the Add and Save buttons, please refer to the LMS guides. Our scenario is a hospitalization. Abuse, neglect, exploitation, and staff misconduct are not involved. Therefore, no targets were identified. I'd like to make a few reminders about the use of the buttons located on the bottom of the screens in EIM. You'll see the back button in the lower right corner of the screen. It can be used to toggle back to a previous screen. Please remember, any data entered onto the screen will be lost if the back button is clicked before clicking Save. Clicking Save and Continue in the bottom right-hand corner of the screen in EIM brings the next screen into view. After completing all screens in the Incident First section, the user returns to the Incident Details screen. The next step is validating the incident first section before submitting. Failure to answer all required questions triggers unsuccessful validation results. The user is notified through invalid response messages displayed in a red text box at the top of the incident screen, as shown here. Specific detail guiding the user to repair the error is located on the incident details screen. By clicking the plus sign in front of the incident first section, a list of subsections appears. The red X in front of reporter information denotes the error location, and clicking the plus sign in front of reporter information reveals the error. Ensuring that all fields with a red asterisk and conditionally mandatory responses are completed will reduce error messages. The green text box denotes successful validation. After receiving this message, the user can click Submit. We encourage a review of the first section for accuracy, paying special attention to discovery date, time, and categorization before clicking Submit. After the incident first section is submitted, the incident final section and management review are created. The incident first section cannot be edited at this time. When a direct service provider is the incident initiator, the assigned service coordinator receives an alert that the incident is ready for them to enter investigation findings. The direct service provider is assigned read-only status. Understanding how to navigate an incident, locate and edit errors, validate and submit are important factors when maintaining 48-hour compliance. We encourage all users to become familiar with EIM and to keep LMS reference guides handy. I'd like to thank each of you for your time today, and I'm going to turn the program back to Damaris to round out our training session.
Thank you, Beth, very much for helping us understand how to document that first section of the incident report. The next few slides will provide you some helpful information, and we will also drop the links on the chat box so that you can click on them and have access to the information. One of the things we want to point out, and actually in answer to some of the questions on the chat, is that if you as a provider or service coordination entity is having issues with the other party not communicating, not being able to get a hold of them, please contact our provider operations hotline at the number shown on the screen, or you can send an email as well to report your concerns. We encourage open communication between service coordination entities and direct service provider agencies, because this is the only way we can work together and make sure our participants are safe. However, if you do have serious issues that you are unable to resolve among yourselves, please contact that provider operations hotline and we'll be able to assist you. If you're having concerns about Community Health Choices participants, you do need to contact the participants' MCO. If you're having issues with the MCO themselves not responding to you, or any other serious concerns that you're unable to resolve, you may contact the same provider operations hotline. The concern will be forwarded to our monitoring and compliance team, and they can take it from there. But please remember that if you have a contract with the managed care organization, you really need to be speaking with the MCO to resolve all of your concerns. As we mentioned during the training, incident management and protective services training is available for providers and service coordinators on the Deering Consulting website. Again, we are dropping the link on the chat for your access. And then there is a page of helpful links. We have a link to the HCSS Learning Management System, where all of the training materials for HCSS and EIM are located. There's an EIM link that allows you to access EIM without needing to go through HCSS. And as promised, there's a link to the state holiday calendar, which is in the Pennsylvania Office of the Budget site. Again, this comes in handy for you to determine which holidays are excluded from the 48-hour count. And then there's also a link for the new 2023 Critical Incident Management Bulletin. I saw a few questions in the chat that are actually very well answered in this Critical Incident Management Bulletin. So I encourage you to please read the bulletin, become familiar with the information, and make sure that your questions are answered. But the bulletin is very clear about requirements and responsibilities, so please make sure you review it. Again, the bulletin is based on the 55 PA Code Chapter 52 law, so it is mandated requirements for your agencies. Some additional information about HCSS Help Desk. They're available to assist you with any system issues or questions. So if you're having issues with accessing EIM, roles for your agency, I did see some things in the chat about not having access to EIM and HCSS. Please remember that when you became enrolled as a provider with the Office of Long-Term Living, you received a welcoming letter. And in that email letter, it explained that you have to make sure you have access to HCSS and EIM. It explained how to have a business administrator in your agency and how to be able to assign roles within your agency. So if you haven't completed that process, please make sure that you go back to your agency administrators and that you review the agency protocols for reporting critical incidents. Not having access to EIM or HCSS is not a justifiable reason to not report critical incidents, because having access to the systems is also mandatory. So there's an 86666 number shown on your screen, but you can also email the HCSS Help Desk. Again, for system-related technical assistance, they will be able to help. If you have actual questions about critical incident reports or critical incident management, you can send an email to our resource account, also showing on the screen. I will now go over some of the questions received in the chat. Give me a few minutes, please, so that I can scroll through the questions. There are some questions in the chat regarding the PowerPoint and recording of the presentation. It will be posted in the Department of Human Services website within the next few weeks for you to utilize with your peers and coworkers. It can also be used by administrators to make sure this training is available to your staff. Next question. Would you please review the parameters for abandonment? Abandonment is a term defined by the Protective Services laws. It is a best practice to go to the Protective Services website to gather information about abandonment. It is actually related to deserting an individual and not providing the care that they need. It's a little bit different than neglect, because abandonment is actually on purpose, someone who ups and leaves a participant who needs their care. We do not have a category in EIM to report abandonment. We ask that reports are submitted under the category of neglect and that the details are explained within the content. Next question. Is there a time frame for reporting past events of abuse? Can the abuse have happened 6 months to a year ago? Yes. Anytime you become aware of a critical incident, you must report it. Your discovery date and time will be that moment that you became aware of the incident. It does not matter if it was 6 months or a year ago, you must still report it in EIM. The date of occurrence is not important as far as the 48-hour requirement. It is your actual discovery date and time. So if it happened a year ago, but you became aware of it today, then March 15, 2023 will be your discovery date, and the time will be 11/16. The next question, what if a participant neglect themselves due to feeling depressed? That is actually reported as self-neglect in EIM, and it is a critical incident. Next question looks like it's a follow-up to the abuse question. If the abuse happened 6 months ago and you just found out, again, you report it using the discovery date and time of when you became aware of the incident. Next question, if a person was admitted into a hospital and then transferred to a new hospital 2 weeks later, does that require another critical incident? If a person is admitted and discharged and then readmitted, then those are two separate critical incidents. If a person is admitted into a hospital and transferred to another hospital within the same hospitalization event, then it is one critical incident report. Make sure the details of the transfer are captured in the content. Next question. If we open a critical incident report and don't have information to complete the report, how do we complete the report? If you're asking from a direct service provider's perspective, the first section, like Beth went over, is really for you to report what you know. What happened? What did you do about the incident? So you should have that information. If it's some secondhand report, maybe a family member contacted you to let you know someone went to the hospital, ER visit, then you can just state in that first section you received a report from a family member about a hospitalization and that you're not aware of the details. You should try to find out from the family members some details about the date or of when the person was taken to the hospital or when the incident occurred. But really, the service coordinator will take over that critical incident in the final section, investigate it, and provide further details within the incident report's final section. Next question. We have a question about serious injury. We had an individual go to the ER after falling and hurt his foot. We filed an incident even though he didn't break it. The doctor said it was a contusion. Should that been filed or not since the injury wasn't that serious? If the person went to the emergency room and they received medical treatment, you report it as a critical incident. The next question, do visits to the ER that did not result in admission need to be reported as a critical incident? Yes. There is a category in EIM for emergency room visits, even though the actual category is not listed as criteria. It does define as the use of a hospital emergency room for situations that are clearly emergencies, such as a serious injury, life-threatening medical conditions, medication errors, as well as when a doctor sends a participant to the emergency room. So yes, those are reportable as critical incidents. What is not reportable as a critical incident is if a participant has a cold and decides to go to the ER instead of the doctor's office, that's not really a true emergency and should not be reported as a critical incident. Having said that, if you're unable to determine the seriousness of the participant's illness or condition, play it safe and submit the critical incident in EIM. Next question, at what point is self-neglect reportable? For example, the client already has a report of self-neglect open in another county. Do I have to make a report as well? If you are aware that Protective Services is involved and the case is still open, then there is no need to enter another critical incident report. However, if there's a new report of need called into Protective Services, it will require an additional critical incident report. The next question, what if the participant turned away the caregivers and does not have informal care, regardless of our attempts to staff them? If the participant's health and welfare are at risk, it is reportable as a critical incident. In this instance, for this question, it will be a service interruption. You just need to document within the critical incident report all of these details, whether the participant refused care and they didn't have informal care. It doesn't matter the circumstances. If the participant is at risk, it's reportable as a critical incident. Next question, emergency room visit turns into 24-hour observation on the critical incident. Would this be considered hospitalization? If the person is not admitted into the hospital, then it would still be an emergency room visit. There is a question or comment on the chat about being new agency and never had any knowledge of the report. I'm not sure what the question is. If you can please clarify, I can look into it for you. If the participant had a tube for kidney and it popped out and he was taken to the ER to get pushed in, but it wasn't admitted, is this a critical incident? Yes, that would be an emergency room visit. Next question, what are the criteria for serious injury? Serious injury is also defined in the critical incident bulletin. Please review the content. It does tell you clearly what a serious injury is. The next question, if a receptionist is the one being provided the initial report, they also have to report. That is within your agency's protocols parameters. So you need to decide within your agency what happens if the receptionist is the one receiving the report. What is the receptionist supposed to do? What I can tell you, as a provider agency, you are responsible for reporting it within 48 hours in EIM and within 24 hours to the service coordinator. There are a few questions, comments in the chat about not having access to EIM and how to get access. Again, I must refer you back to your agency administrator. Make sure you do have access to EIM and HCSS if you are an enrolled provider. If you are providing services in any capacity, you should have received training from your agency's administrator. There is the HCSS help desk that whose link we dropped in the chat for you to call or contact via email to ask questions about how to receive access to the systems. But your agency administrator should have the answers for you on access to the systems. There are some questions here that are related to service coordination. One of them is if there's an ER visit and the person's not admitted, do you need to offer a CNA or an assessment of need? That should be within your service coordination training. Any trigger event needs an assessment. So if an ER visit is the trigger event, then an assessment needs to be completed. After visiting the ER and the client is admitted for other things and is in the hospital, still will be a critical incident. Yes, person is admitted and the hospitalization was unplanned. It is reportable as a critical incident. Next question, is this a change? We have been instructed by counties to report within 24 hours in EIM and have to write a plan of correction as to why we did not. The requirement for the Office of Long-Term Living is to report critical incidents in EIM within 48 hours and to the service coordinator within 24 hours. It has been that way since at least 2015. There are some questions about printing the EIM report. You can print it from EIM if you need to. Make sure that if you print it, you dispose of it appropriately and that you follow confidentiality rules. Some questions about Office of Developmental Programs. We are not responsible or have oversight of Office of Developmental Programs incident, so we are not able to answer those questions. Are there any consequences for agencies who do not report incident reports and do not contact the MCO service coordination involved? Yes, there are sanctions and there are disenrollment consequences for individuals who continuously fail to follow the standards and the policies. There's some questions about clarification on reporting abuse regardless of occurrence. EIM would accept the incident due to the discovery date. Remember, the discovery date is when you become aware of the event, not when the event occurred. So you should not have any problems in EIM if your discovery date is today or last week. Next question, we were informed before that if an event occurred on Friday, weekends are not included into reporting or letting the service coordinator know. Is this something new? This is not anything new. It all comes down to your agency's protocols. If you become aware of a critical incident during the weekend, you must report it within 48 hours, which excludes the weekends, but you do have 24 hours to report it to the service coordinator, and that does not exclude weekends or holidays. There are some questions about MCOs being held accountable for making agencies aware when service coordinators change. Again, if you have a contract with an MCO, you need to resolve your concerns and issues with the MCO. It is 11:29. There is another question, maybe two more. I will try to get to it quickly. So it means that 48 hours after the SC is informed is when the first section of the report must be completed, excluding weekends. If you're a direct service provider, you have 48 hours from when you became aware of the incident. If you're a service coordinator, you have 48 hours from when you became aware of the incident. And then there's a question about clarifying the scenarios. If the service provider is not scheduled during the time and the backup caregiver is in place, you would not report. Whoever becomes aware of the event has to report it within 48 hours. We're out of time. It is 11:30. I hope that I answered all of your questions. I'm sorry, there's another one asking if verbal notification is sufficient as notification to the participant that a critical incident is reported. Yes, if you document your verbal notification, it is sufficient. You have issues sending messages to the SC or the provider, you need to work that out with the agency. Again, we just want to emphasize whoever discovers the critical incident, regardless of your role, you can be a direct service provider or a service coordinator. If you discover the incident, you have to report it within 48 hours. If you're not sure if it's been reported, report it in EIM. If it's a duplicate, we'll take care of deleting it from EIM. We're out of time. Thank you all for joining today. We appreciate your attendance and your attention. Have a great rest of your day, and we hope that you're able to access this information from the website and you can use it internally to have a reminder of your critical incident management timely requirements. Have a great day.